Good day, sir. I am Ramazes Palacio.
And I am Fretzgine Lou Manuel, and today we'll be having our case presentation about malaria.
Malaria. So this is our institutional vision and mission, and also our School of Nursing vision and mission. So for the general objectives, at the end of the medical ward case presentation, the student nurses will be able to acquire enough knowledge, improve their understanding, enhance their independent and collaborative skills, and to provide holistic care to patients with malaria. For the specific objectives, at the end of the case presentation, the student nurses will be able to define what is malaria, identify the causes and factors that can lead to malaria, discuss the signs and symptoms of malaria and treatment, review the anatomy and physiology that is in relation to malaria, formulate and discuss a nursing care plan based on actual high-risk health needs, discuss the disease process and its pathophysiology, and also provide and discuss the related article. So first, what is malaria? So according to the World Health Organization, malaria is an acute febrile illness caused by Plasmodium parasites, which are spread to people through the bites and infected female Anopheles mosquitoes. According to Beleza, she suggested that it is one of the most widespread infectious diseases known to humankind. Malaria also ranks among the world's top mortality and causes of morbidity. It mostly occurs in tropical and subtropical regions such as Sub-Saharan Africa, Asia, and Latin America, where the parasite-carrying mosquitoes are found. So in the Philippines, in the past, the prevalence of malaria was high. However, owing to the National Malaria Control and Elimination Program, valiant efforts, cases and deaths have drastically decreased, and the nation is now inching closer to malaria eradication in order to achieve universal coverage with high quality assured malaria diagnosis and treatment, develop governance and human resources, sustain the necessary financial support, and ensure timely and accurate information management. And this initiative is focused on the health system. So what are the causes of malaria? We have the endemic areas. These are individuals with malaria would typically acquire the infection in an endemic area following a mosquito bite. And also the transfusion. The cases of infection secondary to transfusion of infected blood are extremely rare. The poor immunity. The outcome of infection depends on host immunity. Individuals with immunity can spontaneously clear the parasites. In those without immunity, the parasites continue to expand the infection. And also for the climate is a key determinant of both the geographic distribution and the seasonality of malaria. Without sufficient rainfall, mosquitoes cannot survive, and if not sufficiently warm, parasites cannot survive in the mosquito. So these are the etiologic agents. We have the Plasmodium vivax. If this kind of infection goes untreated, it usually lasts for 2 to 3 months with diminishing frequency and intensity of paroxysms of patients infected with P. vivax. 50% of experience a relapse within a few weeks to 5 years after the initial illness. P. vivax infects only immature RBCs, leading to limited parasitemia. We also have Plasmodium malariae. The persons infected with this species of Plasmodium remain asymptomatic for a much longer period of time than those infected with P. vivax or P. ovale. The recrudescence is common in persons infected with P. malariae. We also have Plasmodium falciparum, which is the most malignant form of malaria it is also to infect RBCs of all ages, resulting in high levels of parasitemia, Sequestration is a specific property of falciparum as it develops through 48-hour life cycle, and the organism demonstrates adherence properties which result in the sequestration of the parasite in small post-capillary vessels. And then the Plasmodium ovale, these infections are similar to P. vivax infection, although they are usually less severe. P. ovale infection often resolves without treatment, similar to P. vivax, and it infects only immature RBCs, and parasitemia is usually less than that is seen in P. falciparum. So for the incubation period of malaria, it is usually 9 to 40 days, and the mode of transmission is the bites of Anopheles species mosquitoes. So we have here the clinical manifestation. Usually in the first stage, we have the cold stage, the sensation of cold and shivering. So it will manifest like flu-like symptoms. In the hot stage, there could be fever, headaches, vomiting, and seizures, usually in young children. And sweating stage, the patient experiences sweat, also called diaphoresis, excessive sweating, shall return to normal temperature, and tiredness. So these are the signs and symptoms. We have the fever, the sweat, the chills, the headaches, the malaise, the muscle aches, nausea, and vomiting. So the risk factors, it will further discuss in the pathophysiology. We have the precipitating factors, the location, socioeconomic status, and the age. And the predisposing factors, we have the environmental sanitation, the protected home, and the no self-protection. So for the diagnostic examination, the blood smears. So it is supported by identification of the parasites on a thick or thin blood smear. So then we also have the rapid diagnostic test, which is the immunochromatographic test that is based on the antibody to histidine-rich protein 2, parasite LDH or Plasmodium aldolase appear to be very sensitive and specific. We have the PCR and also the nucleic acid sequence-based amplification. So these are the nursing and medical management. We have to obtain the history, if there could be any remote or travel, history of travel, and also the demographic data. It will determine the patient's immune status, the age and pregnancy status, any allergies or medical conditions. And also we have to prevent the infection, improve the tissue perfusion, improve fluid volume, regain normal body temperature. We have to prevention, avoid mosquitoes by limiting exposure during times of typical blood meals, consultations, and also the anti-malaria drugs. So the anti-malaria drugs, we have the atovaquone, chloroquine, doxycycline, mefloquine, primaquine, proguanil, and tafenoquine. And for the prevention and control, this is based on the World Health Organization, where the vector control, which is the vital component of malaria control, and elimination strategies, as it is highly effective in preventing infection and reducing disease transmissions. So we have the two core interventions, the insecticide-treated nets and the indoor residual spraying. And also for the preventive chemotherapies is the use of medicines either alone or in a combination to prevent malaria infections and their consequences. And the vaccine, since October 21, the WHO also recommends broad use of AS01 malaria vaccine among children living in regions with moderate to high P. falciparum malaria. transmission, and the vaccine has been shown to significantly reduce malaria and deadly severe malaria among the children.
Say for the anatomy and physiology. Okay, so for the anatomy and physiology, first we have the anatomy of the blood. So the blood is a circulating tissue composed of the fluids like the plasma and its cellular components. They are erythrocytes or the red blood cells, the leukocytes or the white blood cells, and the thrombocytes or the platelets. So by volume, the red blood cells consumes about 45% of the whole blood. The plasma is about 54.3% and white blood cells about 0.7%, while platelets make up for less than 1%. Although it consists of cells suspended in fluid, blood is still considered a tissue as it is technically a type of extracellular matrix. So blood enables transport of cells and molecules between parts of the body like the oxygen, carbon dioxide, glucose are among the most vital molecules transported in blood. Blood cells are essential for normal metabolic and immune system function. So some of its parts are the erythrocytes or the red blood cells. They contain hemoglobin molecules which bind to oxygen so it can be transported to the tissues. They also bring nutrients to the other parts of the body or the organs. So they are one of the main targets of malaria infection because malaria infection will feed on hemoglobin to multiply and they will cause a rupture in the hemoglobin, which will be further discussed in the pathophysiology. So next will be the leukocytes or the white blood cells. They are the soldiers or the main uh, uh, they are the main functional component of the immune system. So they destroy and remove all or abnormal cells in the body or any pathogens that they can find. They will be responsible for the immunity of a person. The next would be the thrombocytes or the platelets, which only compose of less than 1% of the blood. Their main function is for coagulation or clotting, so they will prevent bleeding in your body. And wala. So the platelets carry sticky surface or they have sticky surface that allows them to accumulate at the site of a broken blood vessel or tissue to form a clot, due in part to the release of clotting factors that occurs during endothelial injury to blood vessels. So their main function is to prevent bleeding. So the next anatomy or organ will be the liver. So the human liver is both the largest internal organ because ang external organ na largest is skin. So and also the largest gland in the human body. So it is a soft pinkish brown triangular organ normally weighing about 1.44 to 1.66 kilograms. The liver has a wide range of functions including detoxification, protein synthesis, and the production of biochemicals necessary for our digestion. It is located in the right upper quadrant of the abdominal cavity, resting just below the diaphragm. The liver lies to the right of the stomach and overlies the gallbladder. It is connected to two large blood vessels, the hepatic artery and the portal vein. The hepatic artery carries blood from the aorta to the liver, whereas the portal vein carries blood containing the digested nutrients from the entire GI tract and also from the spleen and pancreas to the liver. These blood vessels subside into capillaries, then lead to a lobule. So this is one of the main targets malarial infection. It's where the parasite will replicate and mature for erythrocytic invasion or invasion cell. So that will be all for the anatomy and physiology.
Hi, so today we are going to discuss our nursing care plan. So this is based on the actual high risk needs of our patient having malaria. So first, di ba, we have ABC, so airway, blood circulation. So circulation, of course, the priorities for we have the diagnosis first. We have the ineffective tissue perfusion related to destruction of red blood cells and decrease in cellular components needed for the life distribution of oxygen and nutrients in the body. So usually the patient would manifest in the assessment subjective. The patient would complain of fatigue and difficulty breathing. The objective for this, according to what the student or the nurse would obtain, for the physical assessment, usually there could be presence of pallor and decreased capillary refill time, so less than na siya, 3 seconds. And the vital signs, the heart rate would increase, and since dyspneic man siya, so could be the respiratory rate would decrease. Kaya maglisod. Magpaspas mo. Increase na siya. So for the laboratory results, the CBC would naa siya low hemoglobin, and the blood smear would indicate malaria parasitic infection. So for the planning, at the end of our 8 hours care, the patient will be able to, for the long-term goal, we to able to demonstrate increased perfusion as individually appropriate. For example, skin is warm and dry, peripheral, pulses present, and strong absence of edema, free of pain or discomfort. For the short-term goal, the patient will be able to maintain the vital signs with a normal range for the HR 60 to 100 beats per minute, and also the RR 12 to 20 breaths per minute, and it will able the patient will be able to demonstrate hydrated skin and mouth and demonstrate appropriate lifestyle modifications to support adequate tissue perfusion. So for our implementation, the independent intervention first. This is what the nurses would do. They assess the vital signs, capillary flow test, and the echocardiogram. So this is to identify the extent of perfusion tissues and assess the skin color and temperature in all extremities for changes that might indicate circulation, and monitor hemoglobin levels. Hemoglobin is a red blood cell component that carries oxygen through the body. So if hemoglobin is decreased, less oxygen will be perfused through the body and tissues. We also have to determine the pulse equality as well as the intensity. For example, the pounding is normal, diminished, or absent, and compare with an affected na extremity. This is to evaluate the distribution and quality of blood flow and success or failure of therapy. We also have to note the client's nutritional and fluid status. The dehydration reduces blood volume and compromises the peripheral circulation. We also have to position the patient to semi-Fowler's position in order to increase the oxygenation of lungs, and advise the client to avoid strenuous activities to conserve oxygen tissues and prevent fatigue. So dependent intervention, this is in collaboration with the doctors and other health workers. So refer to the doctor for further intervention. You have to administer fluids, electrolytes, nutrients, and oxygen as indicated to promote optimal blood flow, organ perfusion and function. Administer anti-malarial drugs to treat malarial infection, and do a cross-match in RH typing for possible blood transfusion as needed. So this is to replace the red blood cells. Usually in malaria, the patient would manifest a low hemoglobin in the laboratory. Kuan. So for the evaluation, at the end of our 8 hours care, the patient will be able to, for the long-term goal, partially met, demonstrated increased perfusion as individually appropriate. Then fully met, ang short-term goal, fully met na ang maintain vital signs within normal range. Partially met ang demonstrate hydrated skin and mouth. and fully met and demonstrate appropriate lifestyle modifications to support adequate tissue perfusion. So for our second diagnosis, we have deficient fluid volume related to excessive sweating and dehydration. So for the assessment, we have subjective data is which results nga the patient complains of nausea and vomiting. And then for the objective data in the physical assessment, usually the patient would manifest as poor skin turgor and decreased capillary refill time. So the vital signs for this one is the temperature it would increase, the BP or the blood pressure would um, decrease, so hypotension, hypotensive ang patient, the HR would increase, kaya mag-compensate, and the INO in the decreased iyang urine output. Okay, deficient na iya ang fluid volume, so low. In the laboratory results, usually the CBC would low iya ang hemoglobin, and the blood smear would indicate malarial parasitic infection. So for the planning, at the end of our 8 hours care, the patient will be able to, for the long-term goal, maintain fluid volume at the functional level as evidenced by um, individually adequate urinary output, stable vital signs, moisture mucous membranes, and good skin turgor, and demonstrate behaviors to monitor and correct deficit as indicated when condition is chronic. For the short-term goal, the maintain urine output within normal range, usually in greater than or equal to 30 ml, and demonstrate vital signs result within normal range as evidenced by temperature within 36.5 to 37.5 degrees Celsius, ang blood pressure within less than 120 ang systolic o less than 80 ang diastolic, and ang heart rate usually 60 to 100 beats per minute. Sir, 100 beats per minute na siya. And the patient would appear relaxed and well rested. So for the implementation, we have the independent intervention where we have to monitor the vital signs, in order to provide baseline data, measure blood pressure, it may be low, so with the client lying, sitting, and standing when possible, and monitor invasive hemodynamic parameters as indicated. These signs indicate sufficient dehydration to cause poor cerebral perfusion or electrolyte imbalance. So note the presence of physical signs, example, ang dry mucous membranes, spore skin, turgor, or delayed capillary refill, and also we have to note the changes in usual mentation, behavior, or functional abilities. Example niya ay ang confusion, the falling, loss of ability to carry out usual activities, lethargy, and dizziness. So the rationale for this one are the same as the number 2, which would indicate sufficient dehydration. And I encourage small frequent meals, of course, because there would be nausea and vomiting. So this is to prevent dehydration and until further vomiting is no longer observed. And we have to instruct in signs and symptoms indicating the need for emergent or further evaluation and follow-up to facilitate timely intervention to prevent or these complications, and also discuss importance of adequate fluid intake at all times and ways to improve hydration status when ill or when under stress. So this is to prevent dehydration, and dependent to collaborate with physician to identify or characterize the nature of fluid and electrolyte imbalance. So this is dehydration is often categorized according to serum and sodium concentration. So para makabalota and for nurses to know, and administer fluids and electrolytes is indicated. Fluids used for replacement depend on the type of dehydration present and the degree of deficit determined by age, weight, and type of conditions causing the deficit. And for the evaluation, at the end of your 8 hours care, the patient will be able to, for the long-term goal, so partially met pa ang maintain the fluid volume at the functional level as evidenced by individually adequate urinary output, stable vital signs, and moist mucous membranes, good skin turgor, and partially met ang demonstrate behaviors to monitor and correct deficit as indicated when condition is chronic, and fully met ang maintain urine output within normal range and less greater than or equal to 30 ml. Fully met ang demonstrate vital signs results within normal ranges evidenced by temperature within 36.5 to 37.5 degrees Celsius and blood pressure within greater than less than 120 systolic and less than 480 less than 80 ang diastolic pressure, and the heart rate is 60 to 100 beats per minute, and partially met ang appear relaxed and well rested. Sir, 100 beats per minute yun na siya. Nasa'yo lang nalibat ako. And for the last diagnosis that we have the hyperthermia related to systemic infection and dehydration as evidenced by elevated temperature. So, for the subjective data, usually the patient would complain of high fever, headache, chills, shivering, and body aches. In the objective data, the physical assessment the patient would manifest in skin is warm to touch and dryness of skin, can be dehydrated, and then the vital signs, temperature niya increase, ang HR pod niya increase, and the laboratory result, ang CBC, usually ang WBC niya mag-increase, ang ESR pod niya kay mag-increase pod, and the blood smear indicates malarial parasitic infection. So at the end of our 8 hours care, the patient will be able to, long-term goal nato is to maintain core temperature within normal range. Ang short-term goal is to demonstrate behaviors to monitor and promote normothermia and maintain urine output within normal range, usually greater than or equal to 30 ml, and the patient would appear relaxed and well rested. And for the implementation, so the independent intervention, we have to monitor your core temperature by appropriate routes. So ang tympanic, then rectal. So note the presence of temperature elevation. So diba 37 degrees Celsius or to 38 degrees Celsius. So rectal and tympanic temperature most closely approximate core temperature. We also have to monitor the heart rate and rhythm. Dysrhythmias and electrocardiogram changes are common due to electrolyte imbalance, dehydration, specific action of catecholamines, and direct effects of hyperthermia on blood and cardiac tissue. We also have to monitor the environmental temperature, remove excess clothing and blankets, and encourage wearing loose clothing, to promote heat loss. Then also, we have to monitor the daily weights to ensure patient has proper intake of fluid and nutrients, and monitor intake and output to ensure patient has proper fluid intake. Monitor use of hypothermal blanket and wrap extremities with bath towels para ma-minimize iyang shivering, and maintain bed rest to reduce metabolic demands and oxygen consumption, and discuss the importance of adequate fluid intake at all times and ways to improve hydration status when ill or when under stress. Example, when mag-exercise or if hot ang environment to prevent dehydration. So for the dependent intervention, we have to refer to the doctor, of course, for possible complications and in order to assess the need for intervention, and assist with internal cooling methods to treat malignant hyperthermia, to promote rapid core cooling, and provide supplemental oxygen to offset increased oxygen demands and consumption. Administer antipyretics orally or rectally. Example, ibuprofen or acetaminophen as ordered to reduce fever. Administer medications indicated to treat underlying cause such as antibiotics for infection, katong mga anti-malarial drugs, and administer replacement fluids and electrolytes to support circulating volume and tissue perfusion. So that's it for our nursing care plan.
So good day, sir. Today I will be presenting the pathophysiology of malarial infection. So let's start with the risk factors for malaria. So the predisposing factors or the modifiable factors would be the environmental sanitation, unprotected home, and no self-protection. So environmental sanitation, usually priority sa tanan, iwas lang or destroy breeding sites for mosquitoes. And then unprotected home would be wala kang mga precautionary measures sa inyo, also sa yourself that kanang maiwasan nimo ang mga bites of mosquito like kung insect repellents or mga mosquito nets. And then precipitating factors or the non-modifiable factors would be sa location. There's usually abundant Anopheles mosquitoes sa tropical countries like Philippines. Socioeconomic status would be sa inyong home if your home is prone for mga breeding sites sa mosquitoes, and age should be if you're too young or you're too old, so immunocompromised ka or low immunity, so risk ka for infection, and then if you have any autoimmune diseases. So let's start with the transmission. So for the transmission, the female Anopheles mosquito nga infected with malaria. So female kay usually ang female na may feed of blood sa humans. So the etiologies would be the Plasmodium parasite. Plasmodium parasite, and actually 4 species. The first would be the Plasmodium falciparum. This is the most fatal species malaria, and then the Plasmodium malariae, Plasmodium vivax, and Plasmodium ovale. So they live in the salivary glands of the mosquito, Anopheles mosquito. So they start as sporozoids, and then they will inject, or if they will start feed na tayo mo feed sa blood sa tao, they will infect sa circulation first, but wala pa na siya mahimo nga mga symptoms or cells infection. Kaya mag-travel pa siya padulong sa liver, and then sa liver dito na siya replicate inside the hepatocytes or the cells of the liver. Then the sporozoids will reproduce asexually, asexual reproduction na siya, maturing into schizons. Can you see schizons? So ang schizons is cluster na siya or groups of sporozoids, may tawag na niya. So ang tawag niya is schizogeny. So asexual reproduction of sporozoids. And then a huge number of schizons will rupture the hepatocyte or the liver cell. They will all continue to multiply, and then so, usually 7 to 10 days na siya from infection sa liver mag-multiply ang sporozoids sa hepatocyte, and start to rupture, release na siya og mga merozoites. So merozoids muna siya ang second na form or stage sa malaria infection. Gikan sporozoids mag-form siya into merozoids. So same na siya nga parasite na bago lang yung form para mag-ready siya for infection. So sometimes may chance nga ang sporozoids is mahimo siyang dormant or mag-hibernate siya sulod sa or inside the hepatocytes. So this would they will become asymptomatic and can cause latency or relapse of malaria. Usually several months to 4 years pa siya ay mahibawan nga siya malaria kaya stay siya inside sa hepatocyte sa liver. Usually ang species ana is ang Plasmodium vivax and Plasmodium ovale. So and then if time na infect sila, so they will then form into merozoites. So I remember nga one sporozoid can develop to 20,000 merozoites. So kusog kay siya or paspas kay siya nga infection sa liver sa blood. Then after merozoites na siya, they will start to katong ganiha sporozoites taman sa formation of merozoites nga mag-release. is exoerythrocytic cycle pa to siya. Exoerythrocytic meaning outside pa siya sa bloodstream or sa circulation. So next will be sa erythrocytic cycle na ta. So kani siya is na siya sulod sa blood o sa circulation na siya. So it affects the circulation sa blood, and then musulod sila or ma-enter sila sa red blood cells, mga ilang main target. And after entering red blood cell, they will enter the ring stage, or they will transform from merozoites into tropozoites. So muna siya ang ring stage. And then they will continue to multiply. Magtipog-tapon na sila managhan, called the exosomes. It used to multiply formation zones. Muna kaya po itawag sa cluster or group of tropozoid inside the red blood cells. Yeah, each number replicates inside the red blood cell. And then rupture siya, release na po siya o merozoids. So balik na po merozoids sa tropozoids. And after releasing tropozoids, mag-start na magawas ang symptoms. But before ito sumagi sa symptoms, ito siya ay asexual reproduction ng kapundutanan. Some tropozoites or sa ring stage would become gametocytes. So pwede siya mahimong male and female nga gametocytes. So this would be para siya sa sexual nga reproduction. Sulod pa rin siya sa blood. If masulod naman sila sa blood, so nanay male and female na siya gametocytes. And then if na uninfected nga female anopheles mosquito nga mobite sa human, pwede niya makuha ning gametocytes nga malaria, and then sulod sa iyang stomach or siyang guts. And then sulod sa iyang guts mag sexual reproduction dito, ang gametocytes forming a zygote. So muna siya. Ang tawag niya ng cycle is chorionic cycle or sexual production of malaria. Kaya gamit ang male and female. And then form siya into ookinet. And then slowly forms into an oocyte. So if form siya ka oocyte, multiply siya, mag-grow, and then rupture. After rupture siya, ma-release siya o mga sporozoites. And then the sporozoites will stay again sa salivary gland sa mosquito. And then mabalik siya start sinugdanan. Transmission na po din siya, mabalik siya og laing humans, and then the cycle will continue. So after that, kung sa among siya cycle sa mosquito nga maka-infect na puglaing ikan sa human. Then balik ta sa rupture and release of merozoites gikan sa ring stage, maggawas ang mga symptoms. So one of the symptoms would be fever and chills. So fever and chills, so ato nursing diagnosis would be hyperthermia related to systemic infection and dehydration as evidenced by elevated temperature. So interventions would be to monitor core temperature, tepid sponge bath, increase fluid intake, and monitor input and output of the patient. And another would be nausea, vomiting, and diaphoresis or excessive sweating. So nursing diagnosis would be deficient fluid volume related to excessive sweating and dehydration. Intervention would be to monitor the vital signs, especially ang yung blood pressure, heart rate, and respiratory rate. Kaya ito makabalo if nibalik or namubuog sa volume sa patient. Increase fluid intake, administer IVF ordered by the physician, and also ORS or waiting. So, and then encourage small frequent meals para dili magsige og pamit ang patient. And then another would be headache and myalgia or muscle pain. So for the diagnostic test after magawas ang mga symptoms would be complete blood count. So ang imong expected sa complete blood count would be low hemoglobin, low red blood cell count, low platelet count, and then HMC VMCH and hematocrit sa patient is low. And then high white blood cell, high eosinophils, meaning parasitic infection. So yeah, and then another test would be blood smear. So this identifies if malaria siya and also yung species, and also PCR test or polymerase chain reaction test determines the species of the Plasmodium. And then medications would be anti-malarial drugs. So we have chloroquine, pyrimethamine, atovaquone with proguanil. So duha na sila katambal and Paris. Same with quinine sulfate with doxycycline. So duha na katambal Paris, and then primaquine. So after ma-diagnose and then medication, good prognosis or what's patient sa iyang sakit. Another way po na magawas ang other explanation na magawas ang mga signs and symptoms sa patient would be sugod ta balik sa rupture and release of merozoites sa bloodstream. And then after releasing merozoites, continue siya og infect og lain nga red blood cell. It's a cycle na siya. So bye-bye na siya. So continues to infect red blood cells, and then the infected red blood cells are destroyed by the spleen. Kaya ang trabaho sa spleen, or siyang trabaho is ma-destroy siya ang mga old and mga infected ng mga red blood cells. So mag-release siya ang mga splenic macrophages. So kung macrophages is type of white blood cells na mo-destroy or mo-consume or mo-kaon sa mga infected red blood cells, ano sa mga lain pang mga bacteria or mga pathogens. So, and then maka-cause siya release of pro-inflammatory cytokines. So, kani cytokines, if ma-release ni siya, isa siya sa mga signal sa inflammatory response sa atong body na maka-cause of fever or chills. So, para ma-release ni siya, there's two ways. So, first would be the macrophages are exposed to the parasite. So, if ma-expose din sila mismo sa parasite, makaon nila, maka-cause siya release sa cytokines. And another way is, if a macrophages is ma-consume niya ang infected nga red blood cell sa parasite. If pag-consume sa macrophage itong red blood cell, and then nasa itong parasite, maka-release siya sa cytokines. And then cytokines will signal the hypothalamus, then thermoregulation. So, appear ang symptoms. Another would be balik sa continued destruction of RBC, kaya na-continue og infect sa lain ng mga red blood cells, causing anemia sa patient. So, anemia we have here are nursing diagnosis, ineffective tissue perfusion related to destruction of RBC and decrease in cellular components needed for the distribution of oxygen and ingredients in the body. So, mo na makakasya og anemia kay isa sa mga targets aning malaria is ang hemoglobin. So, mo na siya dito na siya mo feed sa hemoglobin para ma-replicate siya sulod sa red blood cells. So, direkta gikan sa symptoms, and then gikan sa release ng continuous infection niya sa other red blood cells, and continuous niya nga pag-consume sa hemoglobin para multiply. If left siya untreated, can cause sepsis or systemic infection na siya. So, the whole circulation sa blood na ang malaria. And if ang mga red blood cells is infected, may express na siya og surface proteins. So, ang surface sa red blood cells na siya og mga proteins nga pwede siya mo kapit or mahawid sa laing ng mga receivers at mga proteins. So, immune response na siya. So, if ma-infected ang RBC, magawa siya ng proteins para madali siya ma-attach sa mga white blood cells or mga platelets or sa mga tissues na para makuha siya dito, ma-destroy siya. So, ituyo na siya ng immune response sa red blood cells. So, na siya yung mga surface proteins, and then na increase uh, exposure of adhesion molecules in endothelial cells. So endothelial cells, ang inner ni siya nga layer nga cells sa mga blood vessels. So nana siya yung mga adhesion molecules dito, or muna siya yung mga receivers ani mga surface proteins. So muna increase vascular permeability, okay, para masulod po dito ang mga white blood cell. So na-receiver ang blood vessels, and then na-apoy kaning ma-attract ang red blood cells. So there are two ways. If ang infected nga red blood cell dili siya mo bind sa adhesion molecules sa blood vessel, i-consume ra siya or i-destroy ra siya sa macrophages, ngayon sa spleen. So splenic yung macrophages, i-destroy siya dito. But if ang red blood cell nga na surface proteins ma-attach siya dito sa adhesion molecules sa endothelial cells o sa blood vessel, maka-trigger na siya o coagulation or rosetting. Rosetting ang tawagan na mag-form of formation of clusters in which ang infected nga red blood cell agree around a central plasmodium. Uninfected na red blood cell aggregates around a central plasmodium falciparum infected RBC. So ang mga uninfected na red blood cells, ilang tipukan or ilang coagulate siya around sa mga infected nga mga red blood cells sa malaria. Coagulate apil na to ang mga white blood cells and mga platelets para dili siya maka-infect og lain, mura siya og itabunan siya. Muna rosetting or mag-coagulate siya inside the blood vessel. So this triggers tissue inflammation. Kaya na ma-react naman itong mga white blood cells. So leukocyte infiltration into the tissues. So the blood vessels and other tissues. And the clot naman siya dito, it can cause inflammation and obstruction sa vessels. And then systemic mo na siyang infection na, sepsis naman siya, so it can happen sa asa na sa body. Can occur on different organs during sepsis. So for example would be first sa kidneys. If doon siya sa kidneys plus anemic pa jud, kaya na-destroy na ang mga hemoglobin, so maka-cause siya renal impairment and metabolic acidosis. Na metabolic acidosis maka-cause of hyperventilation, kay taas naman ang low naman ang oxygen, and then taas na ang carbon dioxide. So mag-hyperventilate ang tao, kay need niya ipagawas itong mga carbon dioxide in exchange sa oxygen, and hypoxia naman ay hypoxia kay low na siya of oxygen, kay sa low hemoglobin. Kung sa brain ko ni siya nga area dapat ng blood vessel, makakause siya og cerebral, matawag siya og cerebral malaria, which can be fatal. Makakause ng coma and coma sa patient kaya sa brain. And if sa lungs siya, makakause siya og acute respiratory distress syndrome. So magkagrabe na, also fatal. And if sa pregnant, pwede siyang maadto sa placenta, can cause placental malaria and can be fatal sa mother and also sa baby. So if left untreated ni sila tanan, can cause death.
So for our related article, we have the randomized double-blind phase 2b study to investigate the efficacy, safety, tolerability, and pharmacokinetics of a single-dose regimen of ferroquine with artifenamide in adults and children with uncomplicated plasmodium falciparum malaria. So in this case, this is for uncomplicated plasmodium falciparum malaria, which is highly efficacious single-dose treatments are expected to increase compliance and improve treatment outcomes, and thereby may slow the development of resistance. So there were a total of 373 patients who were treated. So we have less than or equal to 5 years in African patients and 289 African patients of less than or equal to 5 years, and 64 African patients greater than 5 years and old, and 20 patients. So in this case, the efficacy of artifenamide or ferroquine combination was optimal in African children aged less than or equal population of interest, and also the vomiting most likely had a negative impact on the